Yes, I can see you.
Yeah, sir. हो गया अभी शुरू हुआ. Just I'll make you panelist. 1 minute.
Yeah. Yogesh. Yogesh. अच्छा, क्योंकि मेरा वो हो नहीं पा रहा है जो मैं सोच रहा था ना. चलो ठीक है. ठीक है. तो ये डॉक्टर राजेंद्र गनेरीवाल नागपुर के ही हैं. अच्छा ठीक.
मैं आ गया, मैं बोल देता हूँ. या
तो अभी मेरा व्यू कहाँ से जाएगा?
आपका अभी आप पीपीटी ऑन करो सर, सीधा आपका ये दिख रहा है.
ठीक है.
या वी आर सीइंग नाउ.
ओके, स्टार्ट करना है.
एक सेकंड हो रहा है. 2 मिनट. या सिंघवी सर आपका माइक अनम्यूट कर लीजिए. या एंड गनेरीवाल, या आपका भी माइक अनम्यूट कर लीजिए गनेरीवाल सर. Yeah.
Are you able to hear me?
So good evening everyone. Yeah, good evening everyone. Today we have a special topic which we are discussing in our WhatsApp group and everywhere since last 15-20 days, COVID-19, and as a surgeon we should know about it. So we have a panelist. Today we have invited Dr. Rajesh Singhvi sir and Dr. Rajendra Ganeriwal sir as panelist, and our speaker is Dr. Abhishek Katakwar from Hyderabad. So I hand over the proceedings to our panelists, and then they will allow, and then they will start the session.
Good evening all. This is Dr. Rajendra Ganeriwal from Amravati. I welcome you all for this webinar, COVID-19 Surgeon's Perspective. It is a very essential topic in the present scenario. All of us being surgeons are grappling with what to do and what not to do. So this becomes a very important topic. I would request Dr. Abhishek Katakwar to please continue with his webinar and throw light on this important topic. Dr. Abhishek Katakwar, please.
I hope I'm visible.
Yeah,
yes,
I
sir.
can see you, Abhishek.
Okay. Thank you, Dr. Rajendra and Dr. Singhvi, sir. It's first of all, this is my first webinar to Nagpur, and I'm really thankful to ASN for giving me this opportunity. And we know that COVID-19 has really disturbed all of us, not only emotionally, but financially and professionally. And I wanted to cover a few points from the surgeon's perspective. And I hope I would be able to justify by end of talk. And my knowledge about COVID is not as good as the physicians, but I'll try my level best to share all the information what I have. So I have two important disclosure. First is not all the information is published or it's peer reviewed. And on a lighter side, thanks to my wife for sparing me from household work to prepare this talk.
Yeah.
Now
Very.
I'm going to cover it. I'm going to cover it in few points. Like I'll be introducing what is coronavirus, then I'll be speaking about pathophysiology, then clinical features, diagnosis, treatment, importance of mask, because there's a lot of controversy and ambiguity among not only among the physicians but also among the common people. Then I'll be talking about the protection before, during, and after surgery. I'll be speaking about current surgical guidelines during COVID. Then I'll be speaking something about the OPD measures which we have to take in our day-to-day life, because I've got few questions from Dr. Subodh Gupta, and I try to find out whatever answers I can find. Then I'll be speaking about professional hazard and exposure, what you have to do if you think that you're exposed to coronavirus. Then I'll be talking about a few drugs, and it's a vast topic. I'm trying to cover everything in nutshell. Now, coronavirus was, yeah.
Abhishek sir, I have got a message that you are not audible. I'll ask one or two people. Rajendra sir, is Abhishek sir audible to you?
Yes, audible very nicely.
Yeah,
He is audible.
Singhvi sir, audible?
Yes.
Okay, okay. Then go ahead, sir. Go ahead. No issue.
Okay.
Probably some
So
problem.
coronavirus was first named in 1968, and most of you must be remembering that in our microbiology book, there were 4 or 5 lines on coronavirus. That was the only knowledge we had during that time, and now it has taken over. And one of my friend who is a reviewer in JAMA and few of the another peer-reviewed journal from Singapore, he said all these journals are receiving not less than 300 papers and publications in a week, because corona there's a lot of knowledge and information which is coming up. And why this is corona? Because it comes from a Latin word which means a crown, and the size of coronavirus is around 1.25 micron. And we all know that the outbreak is from Wuhan, China, and probably from zoonotic to humans. The diagram which I'm sharing here is important, because I'm not going to go into the detail of how these things happen, but these few things are important to understand, because the E protein which helps in the infecting other cells, then there are bag holding membranes which protects the virus RNA, and then there are N protein, S protein, which I'll be talking about in later, because as we go into the treatment part, we'll come to know why all these things are important. Now let's go into the pathophysiology. What happens when you get infected by SARS coronavirus? Basically, it binds into the human cells by AC2 membrane binders, and ultimately it affects the lung and your cardiovascular system. And when the lungs get affected, the hypoxemia, which is the first sign which happens to the person. So a person might look normal if infected, but he or she might be having hypoxemia. So remember, the first sign would be when you measure the pulse, when you use the pulse oximeter, the first thing which will you notice even before any symptoms occur would be hypoxemia. So this lung injury causes cytokine release. We have been reading a lot about cytokine storm which takes place and which causes damage and vascular injuries. Now, initially, people have thought that the lung injury leads to ARDS, but now there is enough literature which suggests that it is basically something like high altitude pulmonary edema. And that's why a positive pressure ventilation is not recommended nowadays, because it can damage the alveoli more than helping. And when we look at the risk factors, we all know that a person who is immunocompromised or has diabetes, hypertension, or pre-existing elements, they are more prone to develop, get infected and have the disease. Now, when we want to go to the clinical feature, there is a paper published from Wuhan in the 99 cases which they have seen, and most of these patients had symptoms like fever, cough, shortness of breath, and 90% of them had more than one sign or symptom. But a very important point from a surgeon's perspective is 10 to 29% patient will present with initial gastrointestinal symptoms like diarrhea or nausea, which precedes the development of fever and dyspnea. So, might it, the next patient of abdominal pain which you get might be having a corona infection. Now, let us talk something about how does this disease progress. So, clinically, there are three stages, which is early infection, then pulmonary phase, and then hyperinflammation phase. And when we look into the other side, there are viral response phase and the host inflammatory response. So the viral response phase is in which the RNA replicates, and the host inflammatory response in which the cytokine storm takes place and the infection occurs. So in the initial first 3 to 4 days, a person might be asymptomatic but might be carrying the disease. So the first 3 4 days of infection are very, I mean, it's very crucial because nobody will come to know that the person is infected and he will be spreading the infection, as well as there will be no symptoms. Now, there's another paper which is published in JAMA, and they have reviewed around 72,000 patients from Wuhan, and they had 62% confirmed cases, they had 20% suspected cases, and clinically diagnosed 15%, where only the clinical diagnosis was made and no confirmatory diagnosis was made or based on PCR or any antibody testing. Now, the important thing is when we look at the age distribution, 87% of the patients were in the age group of 70 to 80 years. Most of the patient had mild spectrum of disease. And when we look at the mortality, around 15% of patients were more than 80 years, and around 50% of patients who died were in the critical cases, like who had other associated problems like diabetes, hypertension, or immunocompromised, obesity, and liver disease. Now, when we look at the healthcare personnel who were infected, 63% doctors were infected in Wuhan, because that was the time when outbreaks and people were not knowing about. A lot of surgeons or physicians or pulmonologists ignored the disease. We were not knowing much about it, and they had 5 deaths in Wuhan. Now, when I went through the literature, this is a report yesterday. Every day, United States is getting around 31,000 patients they are diagnosing every day. When we talk about India, on average, we are diagnosing around 550 cases per day. And according to ICMR, so far we have around 5,000 positive cases, and every day you can see after 21st of March, the number of cases have really gone up, and on an average we are initially had 100, then 200, and now we are in the range of 500 to 600 patients being diagnosed every day. Now, some of you might think that this could be because of underdiagnosis. We don't have enough inventory, we don't have enough infrastructure, but still we have to believe whatever data is being shared by us. Now, when we look at the diagnostic part, there are you can do multiple tests, but there are a few important things which are evident. So WBC count is more or less it's same. Platelet count is also normal, but if you find anybody who has a platelet count of less than 1 lakh, then they have a poor prognostic value. The lymphocyte counts is normally it's more than 1, but definitely you expect some kind of lymphocytopenia. The C-reactive protein is raised, but when we look at the procalcitonin in a study which is published in NGM, they say that in more than 95% of patients it was less than 0.5. So procalcitonin is not an actual real marker to see a disease, because it can be raised in bacterial infections, but it is not very specific for COVID. Now, let's go into the specific testing for COVID. We know that real-time PCR is the gold standard diagnostic tool, but however, obtaining specimen can have a substantial risk of transmission, and how the specimen was retrieved, that is also important, because if the specimen was not retrieved well, then probably you might get a false negative reports. Now, there's another problem that COVID-19 isn't a binary disease, but there's a spectrum of illness. So sick patients with high viral burden may be more likely to have a positive results, whereas the patients who are in the early phase or who do not have enough viral load, they may come negative. So this thing has to be kept in the mind when you are doing some kind of test. What ICMR has recommended now, that all the patients who have influenza-like illness, they should be tested with antibody testing. So any patient who has a symptomatic influenza-like illness, like cough, cold, or low-grade fever or sore throat, they should undergo a rapid antibody test. If it is positive, then probably patient has COVID-19. And if it is negative, then if required, you would go for PCR. And if PCR is not done, then patient has to be home quarantine, and antibody tests have to be repeated after 10 days. Now, when we look at the timeline graph, uh, the blue line here is the SARS-CoV-2 RNA antigen. The green line here is IgG antibody, and the red line is IgG antibody. So initial few days when the patient is asymptomatic, there will be RNA replication which might be happening, as I've told you before, and then there is a window period for around 7 to 8 days, and then on the 8th day IgM becomes detectable, and which survive till 23 day, and then slowly this antigen disappear by 28 days, but till 28 days, the person is infected. That is very important for us to understand. And the IgG, which usually comes into the picture at around 14 days, and it remains lifelong. So there are, I'm going to share this chart. So a person might have PCR positive, IgM, IgG negative, may be having a window period. Then if person has PCR plus IgM positive, maybe it's early stage of infection. And if all the three are positive, basically it is an active phase of infection. If a person has PCR positive, IgM negative, and IgG positive, then basically it is a late or recurrent stage of infection. If only IgM is positive, then maybe early stage of infection, and PCR may be negative. And if somebody has IgG, then probably it's a past infection. And if IgM and IgG are positive and PCR is negative, then basically it is a recovery phase, and PCR may be false negative. Now, another important diagnostic tool is radiographic imaging. And now I think most of you must have seen this picture in WhatsApp and other social media. The more important thing here is bilateral peripheral consolidation, which one should understand even on the CT. So when we look at the specificity and sensitivity, PCR is it's more sensitive, but CT is more specific, because a person might not show any symptoms, but if he has any abdominal pain or other symptoms, and if you get an CT done, CT chest done, probably you might pick up the early signs of bilateral lung changes. So CT scan has got more specificity as compared to the PCR when it comes to the diagnostic value. Now, this is a treatment algorithm which was recommended by Yale School of Medicine, and I don't want to go into the detail of how these patients are being managed in the critical care, but this is just to give you an idea. A patient with less severe disease, and if the oxygen saturation is maintained, and there's nothing has to be done. But if a person's oxygen saturation is less than 93%, then supportive care has to be started with oxygen therapy. And believe me, high nasal flow oxygen is the best treatment which you can offer to this patient in the initial days. And because nothing has to be done, the only thing is they should not have hypoxemia. That's very important. But if a patient has a fever or signs or symptoms of respiratory disease, then probably, and has a risk factor like age more than 60 or BMI more than 30, diabetic, chronic heart disease, lung disease, immunocompromised, or liver disease, then definitely you have to start treatment. What they have recommended is hydroxychloroquine, which is in the dose of 400 milligrams step, followed by 200 milligram ED for 5 days. And in case if the disease is severe, then definitely along with hydroxychloroquine, they start with tocilizumab, which is an monoclonal antibody, and the dose is around 800 milligram maximum dose, which has to be given. But the thing is, single dose which is coming into the 400 milligram, it costs around 50,000 rupees, and it is available in India, but it's an expensive drug, and it has to be given for at least for 5 days, and then you have to reconsider. There is another thing, the methylprednisolone, which was initially thought to be of not a very useful, but now people are saying that you have to be very liberal in using methylprednisolone, because you can at least prevent the cytokine storm, and before the disease sets in, you have all the things to control. Now, why we should all wear mask? There is a new scientific rationale: you protect me and I protect you. So when we talk about the droplets which are less than 10 micrometer, they are called basically aerosols, and the droplet which are more than 10 micron or up to 100 micron, they are called spray droplets. And when you basically when you exhale, the droplets doesn't go beyond 1.5 meter, but when you cough, it can go up to the diameter of 2 meter. And definitely when you sneeze, large spray droplets can go beyond 6 meter. So that's why when we talk about physical social distancing, we talk about 6 meter, because that is the periphery which you should be considering. So when we compare these three kinds of masks, cloth mask, surgical mask, and N95 mask, when there are around 100 particles, so particles which are leaked through the mask and which you can receive, in case of T-cloth, it could be around 33%, in case of surgical masks around 25%, and with 95 masks around 1%. And when you have when you are wearing any of these kind of mask and when you cough, so particles that are leaked into environment are around 90% when you are wearing a cloth mask. But the important thing here is you might be giving some aerosols, which is 90%, but at least you are avoiding, when you sneeze, when you cough, at least you're not releasing those jets of droplets into the environment which can travel. So that's why this concept of you protect me and I protect you has come into the picture. And we know that the thing which is important for this coronavirus to dock is AC2 membrane protein, which is mostly found in the nasopharynx, followed by bronchi and alveoli. So that's why wearing mask is very important. And in fact, now it has been recommended that everyone, no matter, should wear a mask, even if it is a homemade mask. Now, a lot of people are concerned about N95 mask, whether it can be reused, because it's not about the cost, but it is not available readily. We are having a lot of trouble in getting N95 mask. So there are certain guidelines which have been given by SAGES. So usually this N95 face mask captures around 95% of particle down to 0.3 micron, but 5% may still get through the protection. So when we talk about reuse, so if your mask is not soiled and you know how to take it out, we have seen a lot of videos in which people have used plastic boxes to store the mask. So if your mask is not soiled, you can take out the mask, you can store it in a dry weather for at least 72 hours. When we talk about the mask rotation, there's another guideline which has come from SAGES. You can have 3 or 4 masks and you can dry it for 48 hours, because the content of N95 mask is hydrophobic. So if the outer side is not soiled, then you can definitely dry and reuse it. And when we talk about the decontamination, heat, it's not recommended, but people are still debating on that. The UV treatment is recommended, but only in the hospital-based setting where they have professional UV radiation and not like what we have at the home. Now, the important thing is hydrogen peroxide vaporization. which is the FDA approved, and it costs around 40 lakhs rupees. Not everyone can afford it, but definitely that's the only thing which is FDA approved. Now let's talk about surgical aspect, optimum protection before, during, and after operation. As I said, there is enough literature now to understand what we should be doing in this time of epidemic. So elective surgery with undetected or mild form of COVID-19 may lead to contamination of OR and equipments, risk of secondary transmission, and so you have to consider each patient positive until proved otherwise. And that's why routine or selective screening of patients for COVID-19 before elective surgical procedure it's very much acceptable. Now there are a few things: use of PPE, then intubation risk, then specific operative risk issues, then after operation and recovery, and then what should you be doing when you go back home. We know that PPE includes liquid proof apron, mask, N95, then transparent barriers in the form of face mask, then gloves, then shoes, and the whole covering which you wear it like a boiler suit. Now the use of PPE is, there are 3 recommendations: the green, yellow, and the orange one. The green one is for your day-to-day OPD clinic. The yellow one, in which you have to interact with the patient within 3 feet, and the red one is when you have a high aerosol generating procedure, so that should be followed in the theater. So when you are in the OPD, you can just wear a mask. I'm going to talk about what precautions you have to take in the OPD in my later slides. And the yellow one is when you're supposed to, when you are required to touch or examine the patient, then definitely you as well as your patient both should be wearing a mask, irrespective whether he is positive, suspected, whatever. So make it a rule that all the patients whosoever entering into the hospital premises, they should wear some kind of mask which should be covering the face and nose, and all the patients should be washing or sanitizing their hand before they enter inside the premises. Now we have also seen a lot of videos about proper donning and doffing. So this is how you should be wearing your gadgets and PPE. And when we talk about removal of all these things, the most important thing is, first thing you should be doing is replace the outer gloves with the new one, and then for every step you should be sanitizing your hand, because that is very important. Now intubation risk, the aerosolization or droplet transmission of COVID virus are important hazards for surgical personnel, and mostly seen during intratracheal intubation, tracheostomy, endoscopy, and evacuation of pneumoperitoneum or aspiration of body fluids during laparoscopic procedure. So surgeons and the whole surgical team should remain outside the operating room until anesthesia induction and intubations are completed. Negative pressure operating rooms are recommended. And COVID-19 might remain infectious on different surfaces like cardboard or plastic, so minimum inventory should be there inside the theater. And specially made acrylic boxes for intubation. And what I would suggest is, what we are doing at AIG is, the main theater has been closed down, but the reason was different. We wanted to replace routine filters and other things, but it's surprisingly happened during this time. And we have closed down the main theater, and we are utilizing the other floor theater, which we have around 4 to 5. So I would recommend, if you have any spare theater, use it and close down your normal routine operation theater, because if it's get infected, then it will be very problematic thing. So at least you're using your spare theater, whatever, most of the hospitals have this theater which is for infected patient or whatever. So make it better and utilize it for this time and conserve your main operating room. Now specific operative risk, so minimize night surgery, have minimum number of persons in the operating room including during intubation, no visitors or observers, use smoke evacuator when electrocautery is used, and consider avoiding laparoscopy, because this is what has been recommended by ACS and SAGES and other published studies. Use smoke filters with laparoscopy if you have to use laparoscopy, if at all. Avoid central suction. Close your main OR complex and share spare ORs. Tracheostomy consideration are important because of the high risk of aerosolization. Now, this is a very important paper which is published, and I think most of have seen this paper. And this is about what they did in Wuhan. It is an eye opener for all of us. So they have published a data of around 34 patients who underwent elective surgery, and all of them developed COVID-19 pneumonia shortly after surgery. And 91% patient had the fever, few had fatigue, few had dry cough. And out of that, around 21%, that is 7 patients died, and they died of ARDS, shock, arrhythmia, and acute cardiac injury. And if you see what all surgeries they did was mostly general surgeries, then few laparoscopic surgery, then caesarean section, and few of the spine surgeries. Now, all these patients, most of them got infected. The first sign of symptom happened within 10 days, and surgery was done maybe on the 5th. So there's a very short span of disease. So probably surgical stress or intubation, or there could be other factor like the OT was infected, or the surgeons were infected, or the anesthesia team was infected, or a single person, a team of any single person of the team, if he or she was infected, then probably they are responsible for all this infection and death of these 7 patients. So the current guidelines, US and American guidelines suggest you should not be using laparoscopy unless the benefit obviously outweigh the risk. The only reason is because when we use the laparoscopy, the CO2 what we use and pneumoperitoneum, it can create a lot of aerosol. So even if you want to use laparoscopy, what people have recommended is when you want to release the pneumoperitoneum, use a plastic bag and empty whatever gas is there into a plastic bag rather than opening it into the operation theater. And probably that's the only thing which you can do apart from using CO2 filter. Now, SAGES also recommend the same thing, that minimal invasive surgery could be more riskier than an open surgery, because we know that in laparoscopy artificial pneumoperitoneum there's risk of aerosol exposure. The energy devices produce plump surgical smoke, and the low temperature aerosol from ultrasonic scalpel cannot effectively deactivate the cellular component of virus. And there's enough literature which suggests that a lot of viruses have been detected in the surgical smoke. Thus, the risk of COVID-19 infection in the aerosol should not be an exception. Now, when we compare laparoscopy versus open, the energy devices used for 10 minutes, the particle concentration of the smoke in lap surgery was significantly higher than in the traditional open surgery. And reason may be that due to low gas mobility in the pneumoperitoneum and the sudden release of trocar walls and non-airtight exchange of instruments, or even small abdominal extraction incision can potentially expose the healthcare team to the pneumoperitoneum aerosol. So that's why there's high risk of aerosolization in laparoscopy. So how do you manage this aerosol? So instruments have to be kept clean of blood and other body fluids, and special establishment of pneumoperitoneum hemostasis and cleaning at trocar sites. So you should not be using the routine site. So you have to make some temporary arrangement where you can isolate. As I said, you can use the other spare theater for that. And liberal use of suction devices, but mind it, your suction should not be a central suction, otherwise it will infect and it will help in colonization of the virus. So use a suction which is isolated suction for this time. And remove smoke before converting from lap to open or any extra peritoneal maneuver. And avoid using two-way pneumoperitoneum insufflator, because again it can cause colonization of aerosol into the device. Managing pneumoperitoneum. So even if you have to do a laparoscopic surgery, make sure that you're keeping the settings at the lowest possible level for CO2, and try to reduce the Trendelenburg position time as much as possible, because this will minimize the effect of pneumoperitoneum on lung function and circulation. Now, operative technique: power setting of electrocautery should be as low as possible so that you produce less smoke, and use of electrocautery should be avoided as much as possible. Now, there are HEPA filters, which are basically smoke evacuator system by different companies, which can be used, but the only problem is they're pretty expensive and may not be recommended later on, but this is a need of time, and we should be looking for all such kind of devices. Now, this is pandemic algorithm developed by a few people for COVID, so which clearly states that try to avoid minimal invasive surgery, but even if you have to go for minimal invasive surgery, make sure that pre-operative screening of the patient is negative, and you have enough consent and documentation that there is a risk of person becoming positive post-operative, or it can infect to other people, because he could be in a, as I said, he could be in a initial phase of the disease and may not be possible, might have a PCR false negative results. Now, a lot of us use endoscope and fibroscope and bronchoscope for our routine practice. So this is a recommendation which says that peroxyacetic acid should be used for decontamination and disinfection of all such devices. And after you have completely processed this endoscope with perfusion line and other valves and everything, then you have to keep it in the automatic endoscopic washing and disinfection machine. Now, in summary, aerosol generating procedure increase the risk to the health worker and may not be avoidable, but there is a significant data to recommend against an open versus laparoscopic scope approach. The surgical team should choose an approach that minimizes overtime and maximize safety for both patient and for the healthcare staff. Now let's move towards the after operational recovery. So minimum number of transport persons should be there, and that's why this concept of rotational duty has come into the picture, so that you can avoid overcrowding in the hospital also, because we know that we are not getting a lot of patients. So try to minimize the traffic, hospital employees traffic into the area, and ask them to come in rotation or 2 days a week or 3 days a week. And whenever you're shifting these kinds of patients, you should be wearing PPE, because as I said, until otherwise you have to consider all patients positive. And obviously washing hands and using alcohol-based sanitizer is always recommended. Now, going home, what should be done to keep your family safe? Remember that surface is a known means of transmission of infection. So keep hand sanitizer or disposable gloves when you're going to the ATM or vending machine or gasoline pumps. Clean your cell phone frequently before, during, and after patient care activities. Consider removing clothes and washing them upon arrival home. Follow a free entry till bathroom concept, in which as soon as you reach your home, call your spouse or your family member and ask them to keep all the doors open till the bathroom, so that you don't touch the knobs or you don't touch the doors or anything. And take out your shoes outside, just walk in directly without touching anywhere. Soak your clothes into the hot water with soap, and then you can take a head shower, and then probably things will be better for you. Hand washing frequently is most important thing, and then you may use a 60% alcohol or a 4% hypochlorite to as surface disinfectant. Now, this is the standard guideline which is suggested by British Society. As I said, emergency surgeries: test all your patients for COVID-19, treat all as positive until proved otherwise. Do a CT thorax in all the emergency surgery patients, because you never know, they might have initial CT finding. And then if you're planning a surgery, elective surgery, then obviously you have to take a consent for patient might be getting infected by coronavirus later on. PPE is mandatory. And then we have already discussed about the theater, laparoscopy, and endoscopy part. This is another guideline which is given by SAGES, and I hope most of you must have seen it in the social media as well. Now, there are a few other guidelines which are given by different societies, and this is something related to upper GI. So most of the societies have recommended avoid doing upper GI surgeries as much as possible until it is mandatory or until it is an emergency, because if you do any of these kind of upper GI procedure during this time, you might because it might take a lot of time doing it laparoscopically, and probably it might affect the lung function, and there are high risk of more comorbidities later on. In oncology practice, it has been recommended that there's a higher rate of severe events among cancer patients, specifically if they are on chemotherapy, or if they are immunocompromised, or they had a recent surgery. So you have to calculate and balance the benefit and risk ratio, and avoid surgery as much as possible. And adjuvant therapy may be delayed in early stage of upper GI cancer after curative surgery. Now, as I said, esophageal surgery should be avoided because one lung ventilation is a major concern, and you have to balance the risk-benefit ratio. Appendicitis, if it is an uncomplicated appendicitis, it can be managed conservatively, but there is a high failure rate. So decision based on the surgical judgment is what we recommend for these kind of scenario. Cholecystitis, in a case of symptomatic cholelithiasis, where feasible surgery should be delayed and performed electively. However, in cases of emergency like empyema or other problems which desperately need surgical intervention, then obviously the operating surgeon is the best judge. And healthy patient lap chole, it minimizes the hospital stay. Now, the key principle, which is this slide I'm sharing from one of my friend, who his name is Dr. Asim Sabri, he practiced in Singapore. He said, based on the initial experience in a tertiary hospital in Singapore with 49 cases with 10% intensive care utilization rate, a set of pragmatic principles were used to form a framework for emergency surgical cases to avoid appropriate surgical care and do not deny care to COVID positive, suspected, or positive patient who need emergency surgery. So even if a patient is positive and requires an emergency surgery, definitely you cannot just deny it. You have to go ahead with that. And limit the widespread exposure of healthcare workers. As I said, minimize the traffic. That's more important. And then you have to conserve the capacity of intensive care unit and high dependency unit. And there's no doubt about using PPE for all the healthcare workers. As far as emergency surgery is concerned, we have already discussed about you have to take the swab of the patient, and all the patients should be tested for corona and should be treated as positive until proved otherwise. Now, OPD measures which you can take, which is in last few days, whatever I could gather from information from different literature, I've made my own guidelines. So minimize the OP traffic in your OPD. And most of you, we are well versed with the technology. You can use e-consultation, whether it will be an individual e-consultation, or you can ask your hospital to develop your own e-consultation web portal. A lot of us have our own website. You can connect it to the payment gateway, and you can ask your patient to have an e-consultation with you. So physical visit, if needed, if required, if you feel that on your e-consultation, if you feel that patient definitely need a physical visit, then ask the patient to come. And a lot of people, what they're following in Hyderabad, they ask their patient to wait in their vehicle if they're coming by their own car or whatever. And the front desk person calls each and every person in a row, so that nobody is sitting in the waiting area, and so that you're limiting the traffic. Obviously, as soon as the patient enters into the theater, always have an SpO2 level measured, because as I said, the first sign could be hypoxemia, thermal check, and obviously it is good if you take an consent from the patient, like he might or she might be a carrier for, or maybe infected patient and might infect or get infected later on. And PPE, as I've already discussed, you have to follow the recommendation. Keep all the doors open for your clinic, in fact, your chamber also, because so that no one touches the knob or door. So ask your patient to follow the no touch technique. They should not be touching anywhere. And hand wash and sanitizer at the entry it's what is recommended. And keep minimum stuff on your table. Avoid using computer, phones, or stethoscope, and use 4% hypochlorite or 60% alcohol for surface cleaning of lift, door knobs, table, and chair every day. Now, if by chance you have an occupational exposure to any of these COVID positive patient, and if you feel that it's just an intact skin exposure or a damaged skin exposure, so wash that part with 75% or 80% alcohol, and let it be there for at least for 3 minutes. And if you feel that this is exposure of mucous membrane such as the eyes, so wash it with normal saline, and obviously you have to go for quarantine later on. If it's a sharp object injury, or you have a direct exposure of respiratory tract, then definitely you have to inform the authorities, and obviously self quarantine and observation is the only thing which you can offer to yourself. Now, the last slide is about timeline of experimental COVID-19 drugs. So far around 2 to 3 drugs which are already in the phase 3 trial, like remdesivir and combination of lopinavir and ritonavir, which is already in the phase 3 trial, and probably by end of 2020 we will have few of the drugs and vaccines which will come into the market, and probably we are hoping for the best in coming future. Thank you so much.
Thank you, Dr. Katakwar, for a very lucid lecture. You have nearly covered all the points which are related. One thing I would like to inquire, in remote places, all the hospital surgical units, they have a single operation theater. And if
Yes.
in emergency, what has to be done? Should we make one hospital where we can put all our cases and operate together? Because if we operate in one theater and if it gets contaminated, then we had it. What would your suggestion be?
So, as I said, you have to decide a common theater. If you have a good society and you have a good understanding among yourself, that this is what I would recommend. Make a common theater, and you can pool the money and use that money for common purpose, like for providing PPEs and other things, and all of you can use a common theater, common area, and you will be able to have a better control of infection control rather than using your own theaters.
Oh, thank you.
Nice talk, Abhishek. Really very informative, and I think you have covered all the points very nicely. I want to clarify one or two things, mostly about cancer surgeries. So am I correct to think that we should be operating stage 1 and 2 cancers more commonly than stage 3 and 4? If need be, like for example, if there is a CA anal canal early stage, which I saw just 2 days back, what should be my patient is not in obstruction, patient is not bleeding, but it's an early cancer and patient is fairly young, about 60 years. So should I be operating this patient or not?
Sir, there are 2-3 things which I would like to mention. As I said, if you're planning for any elective surgery, the first thing is you have to make sure that the person is tested for COVID. That's the first thing.
Yes.
Second thing is you have to take a detailed consent from the patient that, okay, after detailed discussion and calculating risk and benefit, you need a surgery because otherwise the cancer may progress. But at the same time, you have to understand that we are having a pandemic where we still do not know who is having this infection. So a person must sign a consent that he or she might get infected in future. So they should be prepared for, because I have heard few incidents in Bombay where patients have blamed doctors and hospital if they get infected.
Hello.
Yes, I can hear you.
Yeah. Yeah, okay. Yeah, point well taken. So the message is operate only when it is absolutely essential. Otherwise,
Yes.
just sit back and just watch.
No,
Any
but
other
what I
questions? Yeah.
what I feel is we just cannot sit back and wait for things to get over, because this is going to get longer, and we should be
Okay.
making new, better policies of how to go ahead. So probably, sooner or later we'll have to make our own choices and go ahead with whatever precautions we can take.
Okay. What have you done about your suction? Because most of our hospitals have central suction. So what, you have purchased new machines? The
So we
old
have,
fashioned.
no, we have some spares suction machines which we used to use in olden days. So what
Yeah.
we are using is we are using those individual suction, and we are following all those universal precautions.
Okay. Any other questions from any other audience?
Yeah, from audience we have many hands raised, sir. So I'll
Yeah.
just take each and everyone one by one. One
Okay.
question is allowed per as a rule which we have made 2 days back. So first question is from Dr. Abdul Qureshi, sir. Qureshi, sir, I am unmuting your mic. Go ahead. Qureshi, sir. Qureshi, sir. Okay, I guess he's. We'll go to next. Sir.
Yogesh, am I visible on the screen?
Dr. Atish Bansod, sir.
Yes.
Not available, sir. Yeah, Dr. Ashok Gajbia, sir. Not available. Yeah, Ashok Gajbia, sir. Your question, please. Okay, he's also not there. 1 minute, 1 minute. No one. Subodh Gupta, sir. Yeah, Gupta, sir, please go ahead. Hello, Gupta, sir.
Not
Yeah,
getting the
Subodh,
audio.
sir, your question. Gupta, sir. No. Yeah, Atish Bansod, sir. Please ask your question. Atish, sir, I have unmuted you.
Can I ask a question while we are
Please.
waiting? Yeah. Suppose
Please.
I operate a patient. I had operated a patient 2 days back, and after
Okay,
2 or 3
Sudhanshu Kote,
days.
sir, you have a question?
Yes, I have a question. Can I
Kote,
ask
sir?
it now? Yes. Can you hear me?
Yes, I can hear you, sir.
My question is about using electrocautery. Now, in many of plastic surgeries, we are almost entirely doing the whole procedure with electrocautery. So what are the recommendations? Of course, it saves a huge amount of time. So electrocautery is quite necessary nowadays. We finish surgeries in almost 1/4 the time if we use electrocautery. So I would like you to tell me how to use the electrocautery and what should be the general settings. It is being said that the general settings should be low, but that seems to be a little, I think, if the electrocautery settings are high, then probably the organism will die faster. So is there any logic in that, and how do we go about using the electrocautery in such procedures?
It's not about the organism which died because of electrocautery. It is about the aerosol which is being produced, the smoke which is being produced. But definitely compared to laparoscopic surgery, in open surgery, it is better, because in pneumoperitoneum, it is basically the gas is under a lot of pressure. So as soon as you release it, it spreads. Like when you sneeze, I've told you, when you sneeze, the droplets go beyond 6 meters. The same thing happens in laparoscopy, because we are used to releasing gas through the trocar. But when we compared it with the open surgery, in case of open surgery, the smoke content, the viral load in the open smoke is less compared to pneumoperitoneum because it is widespread. But definitely, I would recommend using suction, which we routinely use during the open surgery, plastic surgery. But definitely, compared to pneumoperitoneum, it is less. So you can use electrocautery, but at the same time, I also do understand if you keep the settings low, there is more charring and smoking. I understand your concern, but definitely, whatever I'm discussing is recommendations. It's not my personal choice.
Yeah, sure. Thank you so much.
Yeah, Atish sir, go ahead. Atish Bansod sir. Yeah, Atish Bansod sir, go ahead with your question. Hello.
Hello.
Yeah, Atish Bansod sir. Please go ahead with your question. We had Gitanjali. We have Dr. Gitanjali here. Yeah, Dr. Gitanjali, please ask your question. Dr. Gitanjali, not available.
Sir, can you hear
Dr.
me?
Atish?
Yeah, I can hear you.
I'm Yogesh.
Gitanjali.
Okay, let Gitanjali speak.
Okay, Dr. Atish.
Okay.
Hello. Hello,
Yes.
Abhishek.
Yes, I can hear you. Abhishek here.
Abhishek, good evening. A very lucid talk. You have detailed everything about inside hospital OT treatment measures. My question is regarding sanitization tunnels. Hello.
Sanitization of?
Hello.
Yes.
Sanitization tunnels means basically which are coming in a big way, which many hospitals intend to install at their entry of their hospitals. And those sanitization tunnels have been installed in many cities, maybe by DRDO or some private firms. So what is your take on those sanitization tunnels? Should those be installed at the entry point of hospitals apart from following routine for COVID-19?
Definitely these tunnels will be helpful. There's no doubt about it. But aren't we wasting too much of resources on these things if we do not follow the basic things? If everybody is washing their hands, if everybody is taking all the precautions, so definitely then there is a use of it. But if you're not following the basic things like hand washing, proper hygiene, and the more important thing is social responsibility, which we expect from everyone, not from doctors, but each and every individual. And definitely this sanitization tunnels are useful if they have good sensors attached to it, or else it will keep it will keep the jet on and there's no one to utilize that thing, and it will be wasted. I've seen few videos where it has been installed in some of the cities, and I really don't know how effective it is, honestly. Hello.
Okay, Dr. Gitanjali, go ahead. Yeah, Dr. Gitanjali, please go ahead with your question.
Yes, sir. Can you hear me, sir?
Dr. Tanveer?
Yes, I can hear you.
Yeah, Dr.
So, if
Gitanjali,
we
go ahead.
come across a patient of gastric perforation and casualty, if we suspect the patient is COVID positive just because he has desaturation and cough and fever since 2 to 3 days, can we manage such patient?
You mean to say patient is already positive for COVID?
No, we suspect. We don't know the patient is positive or not. But the patient
So as mentioned, you cannot deny you cannot deny surgery to a patient who really needs an emergency surgery, even if he's a COVID positive. But definitely in such scenario, I will utilize all the precautions as I've mentioned, all the PPEs and all those precautions which we can take. Definitely, it's going to be life-saving surgery for that patient, because you cannot keep your patient with perforation, and you should go ahead and deal with that patient, but at the same time, you should also take the swabs for confirmation. If patient has symptoms, you can also go for rapid antibody testing, because anyway you have to do the surgery, but at least if the patient comes positive, the rest of the people, the team can go on home quarantine, and you can have a proper vigilance over the team.
Okay, thank you, sir.
Thank you.
Next question is from Dr. Pradeep Arora, sir. Pradeep Arora, sir, please go ahead. Pradeep, sir. Dr. Pradeep Arora, sir, please go ahead. Doctor.
I think Singhi sir was asking a question.
Yeah.
I think Singhi sir was asking a question when somebody interrupted in the beginning.
Singhi sir, you had a question. One more question, please. Singhi sir.
You hear me?
Yes, I can hear.
Yeah. Suppose I operate a patient today when he is COVID negative, and after 2 days the patient becomes COVID positive. What we should do with the surgical and the anesthesia and the OT team then? Should we all get tested, isolated?
See, the first thing is whole team should go on quarantine.
Okay.
First thing. Second thing is, as I said, there are two methods now which you can do is. One is RT-PCR, but definitely RT-PCR will come positive after 3-4 days. The other thing, if RT-PCR is not positive, then be on home quarantine. Do your rapid antibody test after 2 to 3 days of developing symptoms. If you develop any symptoms like cough or fever, then after 2 to 3 days, you do this antibody testing, because then IgM will come positive.
Okay.
But as I've said, unfortunately, there is more of panic with coronavirus. If you look into I'm not very pessimistic, but if you look into the literature and the data what we have, the more people were dying because of road traffic accident.
Yeah,
and after
correct.
lockdown, there is no road traffic accident, right? And those are the people who were actually died suddenly without any knowing, without any, they didn't know that they're going to die. But at least in corona, we know that, okay, this person is infected, what all precautions we can take. So at least we are saving those lives, but at the same time, we are taking risk of these lives who can get infected. So we have to be really careful about it.
Unmesh Chandak sir. Unmesh Chandak sir, yeah.
Hi Abhishek. Hello.
Hello.
Hi Abhishek. Nice talk. What is your take on hydroxychloroquine prophylaxis for surgeons or OT team?
Yes. So hydroxychloroquine has been recommended in the dose of 400 milligrams start, followed by weekly dose. And initially, few people have used therapy of chloroquine and azithromycin, but we know that it can prolong your QTC interval, and there can be cardiac issues, and in fact deaths have been reported. So I would, and I know that I haven't taken myself chloroquine, and few of my colleagues have tried it because they are more exposed than me. But they had a very unpleasant experience with chloroquine. Not everyone can tolerate it. It gives a lot of very upset. But if you feel that you are at high risk, believe me, I have chloroquine at my home, but I haven't had it so far. But definitely, it has to be taken weekly, but not with azithromycin.
What is the status of antibody testing? I mean, is it available freely to know whether we have already immunity for COVID? I mean, that will kind of make us more.
Yeah, in one of my slide, if you remember, is it visible? Should I go back to the slide?
No. It's okay. You can tell us.
Yeah. So if you see that slide where I've discussed about the antibodies. So
no, is it available? I am asking a practical question, whether we should get tested ourselves for an antibody, whether we have been exposed to COVID and in a way we are now protected from it.
Yes.
So that we can go ahead with.
Yes, you can test yourself, but the problem is if if your both IgG and IgM is positive, then you should be in the recovery stage. And if only IgG is positive
Okay.
and IgM is negative, then basically you had past infection and you have recovered.
Okay.
So this
So
slide
there
is from ICMR guidelines, and these antibody tests are available by labs also.
okay. Thank you. Thank you, Abhishek.
Thank you.
Gajbia, Ashok Gajbia, sir, you have a question? Are you available? Not available. So, sir, most of the questions are done. I don't have any more hand raised up. Pradeep Arora, sir.
Hello.
Pradeep, hello.
Hello, Yogesh. Dr. Subodh Gupta here.
Yeah, Subodh, sir, please go ahead. Sorry.
Yeah.
Good evening,
A
sir.
comment and a question. Most of the surgeries, I believe, if they are possible, they should be done under regional anesthesia. Yeah. Number two, an infection does not mean that you will be immune. You will develop an immunity, a lasting immunity. The studies are not yet complete on this issue. It's a still open thing. Is that correct, Abhishek?
Yes, so we still do not know what happens in long term because
Yes.
some of these patients might remain carrier for a long time.
So people are getting reinfected as well. There are a few cases where reinfection has come up.
Yes, yes.
Yeah. Thank you.
Probably it has something to do with the change in strain. So initially they got infected with some strain, and later on they got
That's
infected
right.
with.
That's right. Mutation is very quick in this virus. Yeah.
Yes.
Thank you.
Yeah, we have Dr. Ritesh Bodede, sir. Please ask your question, Ritesh, sir. Ritesh Bodede, sir. Ritesh, sir, please unmute your mic. Doctor, yeah. Ritesh,
Yeah.
sir, go ahead.
Am I audible?
Yes.
Yes. Yes.
Yeah. Very good presentation, excellent presentation, Abhishek sir.
Thank you.
My point is, what are the current guidelines for operating? Obviously, we are working in government setup. We are not doing any elective cases now, as per the orders. But what orders they have given us, that you have to do only emergency surgeries, and there is no clear-cut guidelines given by the government or ICMR or Ministry of Health regarding use of PPE during operations. They have given guidelines regarding use of PPE in OPD, that too COVID OPD or screening OPD, but not for the routine surgical OPDs or emergency surgical operations. So, do any other body have any guidelines regarding use of PPE during operations and during OPD?
So as I've discussed, SAGES and all the American societies, they have said for any surgeries right now you're planning, even if it is an emergency surgery, you have to make sure that the person is COVID negative. Unfortunately, it is not possible in Indian scenario because of lack of resources. But if possible, please test all your patients before surgery. That's a recommendation.
Okay, but that is not possible. Then the option
If
remaining
it-
with us is use of
Yes.
PPE.
Yes.
But there are no
Then
clear-cut
definitely-
guidelines from ICMR. Whatever
Yes.
guidelines
So
you have told, these are from American Society and SAGES.
yes, though ICMR so far has not given any guideline on
No.
routine use of PPEs, but definitely in few days it will come up, because probably we'll have more production of rapid antibody testing kits, which will be readily available. And recently they have come up with a lot of guidelines, and they have recommendations, and Ministry of Health has recommended that they'll make it readily available. So probably in few days we might expect that at least in the government setup it will be available free of cost.
Yeah, that will be a wonderful thing. Okay, thank you.
Thank you.
And excellent talk once again.
Thank you.
Pradeep, sir, Pradeep Arora, sir, please go online. Pradeep sir, are you available? Yeah.
Yes, I am available. Yes.
Yes.
First of all, wonderful talk, full of contents, and I must appreciate that for a surgical mind, you have learned medical details. So much of medical detail is really unusual.
Thank you. Thank
So
you, sir.
that's
I've already
the
made
thing.
thanks to my wife.
Yeah. Now, a couple of comments, and then I will go on to question. One is that electrocautery in open surgery, it's a good idea to use bipolar cautery because plume is less. Right? When bipolar cautery, the plume is less. The vaporization, lateral damage is less, so evaporation less. And secondly, if you have to use monopolar, desiccation mode is better than fulguration.
Yes.
For the same reason. Now, second comment is, which I think you might have told, it might be just reiteration, the doffing area has to be planned and it should be juxtaposed to OT. And number three, there is nothing like recovery room for COVID patients. They go directly to ICU or isolation and they have to recover on the table only. Just to emphasize, I think you might have told, you have covered all the details actually. Now I will come to question. The question is that, did I hear right that you said that this rapid PCR, the CT thorax is more sensitive? I think you used the word, no, more specific perhaps than RT-PCR.
No,
Did you
sir.
say that?
RT-PCR is more specific.
More specific. Acha, RT-PCR. Yeah, well, that is part of common understanding. Now,
yes,
my question linked with that.
CT is more sensitive because a person might not be a PCR positive if he is still asymptomatic.
But we will replay. I am certain you said the other way. Yeah. Anyway, my question is that this series in which 20% ultimately got infected, 20% the series which is from Wuhan,
yes,
and 20% were died after surgery. Now, these were COVID patients. These were COVID patients, or these were their status was unknown, and still they died.
No, sir. All the 34 patients, they were tested and they came positive.
Okay. Beforehand, before surgery, pre-operative COVID was positive.
No. So basically, what it's a retrospective study in which they found after the surgery was over, all these patients came positive.
I see. So this part didn't come out clearly. That actually they retrospective study picking up only those patients who were post-operatively COVID positive, and it was found 20% died. Right. I got it. So I thought, how could it be prospective? Okay. Thank you very much.
Thank you, sir.
Last question from Qureshi sir. Sir, are you there? Abdul sir? Yeah. Sir, please go ahead with your question. Qureshi sir. Sir, we cannot listen to you. Qureshi sir. Qureshi sir, he is unmute, but I can't listen to his voice.
Even I can't hear him.
Yeah, no. Yeah. So what we'll do is, sir, we'll ask Qureshi sir and all to put their question in your WhatsApp group, ASN group.
Sure.
So that you can answer it there. So we have most of the questions which are answered now. So I thank our chairpersons, Dr. Singhvi sir and Dr. Ganeriwal sir, for giving the time. And I thank Dr. Katakwar for a beautiful talk.
Thank you.
We'll see you tomorrow. Tomorrow we have talk on urology. So we'll see all of you tomorrow. Thank you very much.
Thank you so much.
Thank you, Yogesh. Thank you, Dr. Katakwar.
Thank you.
For a very excellent talk. Thank you so much.
Thank you.
Thank you.
Bye.
Good night.